Hi, Tudor.
Hi, Lauren.
What an incredible plenary today.
Yeah, absolutely incredible. It's nice to see positive trials for a change, huh?
Yeah, and well-designed studies and answering questions, but indeed
Very high quality research.
fantastic. We can start. Can we start with best two?
Let's start with best two.
All right. What did you think?
I mean, I think that best two aligns a bit in terms of, at least in terms of clinical results with Enchanted MT. I think that it's perhaps another myth that is falling because we were maybe too aggressive with blood pressure management in the past, and it makes me reconsider what I do after thrombectomy. I maybe let the blood pressure rise a bit more. I did not see any signals of benefit, any high chance of any trials in the future being positive on the aspect of lowering blood pressure after thrombectomy to 140.
At least not if you're just randomizing patients with no other information, right? I do wonder whether, personalized targets may have promise, but certainly, best two, along with the other studies, doesn't look promising.
Agree. And if you think about it, the reason why we lower blood pressure is to avoid symptomatic intracerebral hemorrhage. There was no hint here that this accomplished that. I mean, you could have maybe expected a neutral result with maybe better outcomes in those who don't have hemorrhage, but a higher rate of hemorrhage in the high blood pressure group. None of that was seen. So I think we need to rethink this concept of lowering blood pressure to avoid intracerebral hemorrhage.
Yeah, I agree. It's nice to see, again, a well-designed trial. They got separation between the 140 group and the other blood pressure group so they could answer the question.
Yeah.
Which was nice.
Well, I think obviously the next topic is the topic of large core. That's kind of
it's a big one.
They dropped the bomb here, right?
Amazing.
So yeah. So
were you surprised?
Well, I was not surprised because of Rescue Japan, but what I was surprised by was that in both trials the benefit seems to be consistent across all time points. So that really was what surprised me. And what I keep being surprised by, in keeping with the results from Rescue Japan, is the treatment effect. That the treatment effect is maybe slightly lower, but not much, than that seen in patients with small and moderate-sized cores. So that's really makes me rethink whether the only benefit of reperfusion is penumbral salvage. Maybe there's other reasons why reperfusion leads to better outcomes that have to do with, I don't know, edema ability to, although edema was higher in the treatment group, enhancing recovery, lowering inflammation. I don't know what the mechanisms could be, but maybe it's just not penumbral salvage, because even when we perfuse these large cores, and we don't have much evidence of mismatch, and in subgroup analysis, mismatch benefited as well in Select 2. So that kind of throws into question the whole mismatch theory.
I don't know if I interpret it that way. When I think about it, I'm looking at, a CT that shows some hypodensity, subtle hypodensity, right? But that doesn't mean that there's 100% cell death in that region, right? We're looking at some swelling, we're looking at delays in cerebral blood flow, but, when we're looking at core by perfusion imaging. But I think there's heterogeneity in that tissue. And so when I look at that, and I'm thinking, well, those large cores are showing us that there's a lot of injury there, but it doesn't tell us, or maybe it doesn't tell us, that there's irreversible and 100% cell death in that area.
You're absolutely right. So to me, it's either reperfusion does things that we don't understand, that's beyond the penumbral salvage, or we are worse than we thought at measuring what's really dead.
Yeah, or how dead is it?
Yeah.
Perfect. What's fantastic, though, to see also is that we didn't see a big shift into a large number of seriously disabled
Yes.
people, right?
Yeah.
We saw a nice expansion of people that were achieving good outcomes, but not at the expense of the disabled. So that was great to see as well.
I do think that these two trials will change selection pathways and systems of care, because our systems of care are so designed around excluding large infarcts.
Yeah, we're going to be transferring a lot more patients in for potential thrombectomy, that's for sure. And for good reason.
Yeah.
Which would be great.
It's another myth that fell, right? The large cores that we initially believed they don't derive benefit, that they actually derive harm, and it's remarkable how things have evolved.
Right. It's nice to make a hypothesis. It's even nicer to prove yourself wrong and show a benefit to patients. So what about there was also a blood pressure trial, the early versus late blood pressure reduction. It sort of seems to support what many of us have been doing for a while, which is kind of let the patients ride for the first week or so and then start treating blood pressure.
Sure, but to me, it's kind of a neutral result. So what I take home from this is that you don't necessarily have to wait, right? We used to, that's another myth right?
That's true.
So we used to think that this is mandatory, that you shouldn't be doing this because you're going to decrease the perfusion pressure and so on and so forth. And this actually strengthens the evidence that existed so far, that the effects are probably neutral. That there's probably as much benefit from lowering blood pressure for other reasons that sort of offsets the potential harm. So good data to rely on when we make these kind of treatment decisions. I personally I'm a bit more aggressive with early blood pressure management. It's good to see that, well,
the outcomes are equivalent, right?
You don't get punished for that.
The other interesting trial was the Aramis, looking at
yes,
alteplase.
Yeah, the problem that I have with these trials is that, indeed, it's very important data, and it's actually the first completed trial that examines this question, because
Prisms had trouble recruiting.
Was stopped ahead of time. But I still don't understand very well what a non-disabling stroke means. Like, you could argue that every stroke is disabling, right? And you could argue that every NIH stroke scale score less than 4 will be very likely down the road to not result in disability. So I think we need a bit more clarity with regards to this definition, because in practice a lot of people still give TPA on the account, of, well, this is a disabling stroke. And the case that Tan showed at the end, and thank you for reminding me to wait for the poll. I think at my hospital, most people would have treated on the account that, well, this is disabling, right? And you can make the argument that it is disabling.
Yeah. Well, I think that's where the long discussions, it's difficult to have those long discussions about what is disabling with a patient in such a time-critical emergency.
Yeah. So I think that's where we need to refine our knowledge a bit better. What truly is the disabling, or should we call all these low NIH stroke scale score disabling versus no? Because we don't do cognitive evaluations. We don't do the more sophisticated stuff, right?
Yeah, but we do need the patient's buy-in, and understand what they do from their daily life. But it is nice to see that, one, the trial completed, as you mentioned, and that this is in obviously a Chinese population, so we'll have to also understand whether it's going to replicate in U.S. populations before, say, I would implement it in my practice here. But it's interesting to think that maybe DAPT is a good alternative in the truly, truly mild disabling strokes.
So,
but more good data.
Speaking of groundbreaking science coming from China, what do you think of the
Tyrofan
trial?
I think that's great. I mean, for those, we never have had something to offer really for those patients that are presenting sort of ineligible for TPA and that were concerned, have a risk of progression or the progressors. So, it makes sense, but it's also really nice to see.
Yeah.
And those are the patients that were not included in Chance and Point, right? And so they weren't getting DAPT currently, and yet we had nothing but aspirin to offer. So now we have something to offer.
This makes a lot of sense because it's kind of a shift towards the earlier time window of a more potent antiplatelet treatment.
Yeah, but without increase, I was worried about risk of bleeding, right, in those more severe stroke patients, and so it was nice to see a benefit.
Yeah, I think it's a very intriguing approach, and I do think we probably will need confirmatory trials in the U.S. population, but another very exciting approach.
Yeah, indeed. And then CMOS.
The
intracranial bypass.
The ECIC bypass trial. Yeah. I must say, as a clinician, I do think that, we have a lot of situations where, endovascular or medical therapy is not enough. So I would love to see ECIC bypass, STA MCA bypass surgery win in a
success.
Trial.
Yeah, to think.
But it's I think it's we're gonna need to go through maybe more iterations. I think perhaps the operative results were a bit better than what we've seen. Not enough to make a difference in terms of a statistically significant difference in outcomes, but perhaps the key is the surgical expertise and of course patient selection. But the conditions that they treated are very high risk with a very poor natural history, and I think we shouldn't give up on this procedure. Is my feeling.
You wonder if what will happen if you could follow those patients longer term. Maybe the 5-year stroke rates will be significantly reduced, and that will show.
Absolutely, I wish we can have these very long term, longer term trials, because maybe at some point you reach that inflection point where you're on the benefit side of the curve.
Yeah, indeed. Or those recurrent events, those patients that have had recurrent events despite best medical therapy. There are patients that are in.
Oh, it's a very sick patient population with a poor natural history. So I think we should keep trying to find solutions for these patients.
Well, again, a lot of positive trials, a lot of really well-designed trials answering questions, and an exciting meeting.
Yeah, and we hope that next year's meeting will give us the same rate of outstanding science and number of randomized trials and really practice-changing studies. So we're gonna end here, and we like to invite everyone to ISC 2024 in Phoenix, Arizona, in 1 year. And thank you, Lauren, for for being such an outstanding vice chair.
It's fun to work with you as chair, Tudor.
Thank you.
See you next year.